So really excellent demonstration of some of the topics that were covered in the panels, both in this second group in terms of new minimally invasive technology in a truly unaddressed or mostly unaddressed field on peripheral disease, and then many of the new approaches as it relates to rhythm disorders. So many thanks to Dr. Dan Clare and Dr. Bruce Lindsay and our team, especially Chip Steiner, who's been working so hard, and Shubayu Basu, to pull this together and give you a really, I think, vivid demonstration of what the technological challenges are. So now we're switching over to a keynote talk by David Snow, the CEO of Medco. And when you look around healthcare and say, who are the people who are changing the way healthcare is conceived, delivered, and paid for, folks like David Snow come right to the top of the list. He's been CEO of Medco since 2003. Prior to that, top leadership positions in a number of healthcare companies. And we're all looking forward to David's talk. It's something that he's he's wanted to come here and be part of the summit. So we're happy to have him and happy to hear this. And Michelle Cortez, per our model, David's going to talk for a bit, and then Michelle's going to have a fireside chat with him. David Snow.
Said I wanna meet ya.
Excuse me.
Next Saturday.
All right, good morning, everybody. Thank you for having me here today. Again, my name's David Snow. I run Medco Health Solutions. For those of you who don't really know who Medco is, we are the largest PBM in the country. We're ranked Fortune 34 right now in terms of revenues at $66 billion in revenue. We are the largest mail-order pharmacy in the world. We serve about 65 million members. We're the largest specialty pharmacy in the country, and where we have grown our business since 2003 from about $30 billion company to a $66 billion company. And I will tell you that the main driver of our growth has been clinical innovation, not in the same way as you saw from the previous speakers, a very different approach to working within the healthcare system to connect disconnected silos within healthcare to drive better outcomes, lower cost. And I want to share with you some of those innovations. We call what we do making medicine smarter. And there are really a number of components to this concept of making medicine smarter. So first of all, we manage smarter medicine, meaning we dispense, when you look at the system and our members, about 950 million prescriptions a year. About 110 million 90-day prescriptions at mail through our own pharmacies, using robotics and technologies that bring the cost of dispensing down dramatically and bring the safety up dramatically, using the Auburn study used at retail to measure error rates per million. Medco's robotics and technologies that Medco invented, they're proprietary, actually increased the safety and reduced the error rates by over 23 times when dispensing meds. We use formularies. We wire everything. The only part of healthcare that's truly wired in this country today is pharmacy, and the PBMs do that. No matter where a patient goes, whether they get their drugs at a retail pharmacy or at mail, we know what the physician prescribed. We know what the patient's taking. We know whether the patient's compliant. We administer the claims payments on all those scripts, and that's managing smarter medicine. We also, in our pharmacies, deliver smarter medicine, and that's one of the big areas where we've innovated, and I'm going to talk more about that in a minute. But bottom line is, because we have so many patients, 65 million people, within our population, we have 5 million diabetics. We have 10 million patients with cardiovascular disease. We have 12 million patients with neuropsych issues. So we've reorganized the way we handle the front end of the pharmacy where the cognitive activities go on. And our pharmacists are deeply trained by specialty, and they only deal with a specific specialty. So, for example, we have over 400 pharmacists who do nothing but diabetes when they're dispensing. They're additionally trained, additionally certified, and we use powerful technologies to actually show our pharmacists what a patient's doing within that disease. We use evidence-based protocols. And we actually populate those evidence-based protocols with real-time data to show gaps in care. It's been very powerful. I'll give you some examples in a minute, but it makes a very big difference. Medco's also made a very big commitment to the whole area of pharmacogenomics. We fundamentally believe pharmacogenomics has the power to take us from shotgun medicine to precision medicine. And I'll show you what we're doing there and how all these pieces fit together. Finally, we also do care about access. And we have a foundation that funds meds for people who can't afford them. And if you think about how we've organized ourselves, we really have the fundamental basics that real healthcare reform in this country should be based upon. Because real healthcare reform in this country should be about access, cost, and quality. What we have right now in healthcare reform is a bill that tries to do something about access. It does very little around cost and quality, and quite honestly, that means we're entering a hyperinflationary environment. And when I spend time in Washington, I really focus on cost and quality because I do believe there's enormous opportunity to improve outcomes at lower cost, and I'm going to talk about that and focus on that for the remainder of this presentation. So let me just quickly tee this up. When you think about our population in this country, and Medco's population of 65 million people very much represents the population in this country. And you look at total healthcare costs. We spend 96% of every drug dollar in this country and 75% of all medical dollars on patients with chronic and complex disease. Right now, today, 50% of our population has one or more chronic or complex diseases. When I talked about this 5 years ago, it was about 45%. It's grown to 50%, and that's the aging of America phenomenon. When you look at the ICD-9 codes and look at what the first line of defense is for these chronic and complex diseases, 89% of all of them use drugs as the first line of defense. So there's a real need to understand what patients do with that first line of defense and how you manage that so people don't need to go to get to that second and third line of defense, which is far more expensive to the system. It's estimated today that because of the poor management of chronic and complex disease in this country, each and every year we throw away $350 billion a year. And they're in two fundamental areas. One is in the adherence area, where patients simply don't do what the doctor told them to do to treat their chronic disease. And number two, and more surprising to people, is in the area of compliance. And it's largely because physicians are having a very difficult time as the knowledge domains get deeper and deeper, faster and faster with keeping up with current medicine. And I'm going to give you some data on both of those things. C. Everett Koop said it well, drugs don't work in patients who don't take them. A.T. Kearney did a study not too long ago that simply shows that patients with chronic disease who should be on their treatment protocol for long periods of time typically fall off within 12 months. 65% of patients on average stop doing what the doc told them to do within 12 months. You know, so these brilliant discoveries we make, these brilliant innovations we have in pharma, honestly aren't working in many, many cases because the patient fails to continue to do what the doc tells them to do for all kinds of reasons. Our therapeutic resource centers have done a huge job closing that particular type of gap in care. It's a very powerful opportunity. What's interesting is when I was running health plans many moons ago, I used to capitate primary care docs. I'd say it's the early precursor to a medical home or an accountable care organization properly structured. And one of the big issues physicians had who were taking risk was they had no clue what their patients were doing in between office visits. The doctor could do everything right relative to treating that patient, telling that patient what to do, but the next time they saw that patient, it was often in the emergency room of the hospital because the patient failed to do what they were told to do, and the doctor got the bill. So, there are a lot of things that we can do with a wired healthcare system, with protocols, with watching what patients are doing in between visits that help an accountable care organization get the job done, that gets at that enormous waste in the system. The other thing that's very clear is right now today, from the time landmark evidence is produced in medicine, it takes approximately 17 years before it becomes standard of practice. And I have to tell you that length of time is getting longer. It's not a physician's fault. My father was a physician. I used to run hospitals. I know what a physician's life is like. It's getting worse, not better. But the real problem is that it's impossible to keep up with the information. If a physician wanted to keep up, they'd need to read 75 primary studies and 11 meta-analyses daily to keep up with the discoveries in medicine. Just to give you an example, when you look at the practice of medicine today, the discoveries that physicians need to know tied to the treatment of patients is growing exponentially. I just want to isolate one area. Since the unraveling of the human genome and the focus on genetics as part of the practice of medicine and the dosing of patients. If you look at what happened between the unraveling of the human genome in 2000 out to 2007, you can see the growth in our knowledge in terms of both diseases and the genes that are related to those diseases. 2008, this is the number of diseases we added to our list. This is the number of genes we added to our list. If you look at physicians' ability, we actually did a survey with the American Medical Association of Physicians about genetics and pharmacogenomics. And physicians readily admit that this is becoming a very important space to understand, and they also readily admit they aren't trained this in med school, and it's impossible to keep up with. Right now, today, 75% of the medications that we dispense have pharmacogenomic information on the label that physicians should be aware of. But I can tell you that when you look at the practice of medicine, no one is doing the genetic testing where it's actually recommended tied to the label. When you look at the physician's inabilities to keep up with the information, there's also, the fact that human cognitive capacity has its limits. On average, this came from the Institute of Medicine, human beings can handle about 5 facts per decision without some kind of technical assistance. And let's assume physicians are much smarter than the average human. I don't think you're going to get much above 6 or 7 before you start to have an issue relative to keeping up with what is the current science is. So, I myself have been a huge advocate of Atul Gawande's, he calls them checklists, I call them evidence-based protocols. But I think that using a wired system, having evidence-based protocols to bump up against for a patient with a disease, making sure those protocols are robust so that there's actually decision trees, if this, then this, is fundamentally powerful when it comes to closing compliance gaps. Right now, our specialist pharmacists are calling physicians when they're not using the most current science. Those conversations are a little bit harder than when you call a patient who's non-compliant, but we are making enormous progress, and there is a real partnership being created as physicians realize these pharmacists are focused on clinical issues, not administrative issues when they're calling. When you look at what we do now, I told you that pharmacy is 100% wired today. We're actually operating under evidence-based protocols. We actually can see exactly what a patient's doing relative to what a patient was told to do. We can also see what a physician is prescribing real-time tied to what we see in claims history. Our pharmacists do nothing but work with patients and pharmacists every day. We close gaps in care. We're actually at risk for gaps in care with our clients. And we actually did a very large study with 6 major clients representing 600,000 lives, looking at gaps in care for cardiovascular disease, diabetes, and pulmonary disease. We found consistently at a patient level, these clients all had utilization review companies, managed care companies doing disease management and case management, but they all universally had 25 to 30% gaps in care, steady state, Six Sigma charted. We turned on these therapeutic resource centers for that defined group, and in 90 days we closed 80% of the gaps in care. And once you close those gaps in care, we are finding that recidivism does not occur. These patients, when they're properly taught about the risks of not doing what their doctor tells them to do, they do the right thing. It's just a very powerful way to create this safety net to drive the kind of outcome we're trying to achieve with patients. If you look at the results, you can see them here. This is for diabetes. You can see on the x-axis is compliance rate. The further out on the x-axis you go, the more compliant the patient is with the treatment protocol. On the y-axis is cost per member per year. And you can see that as the compliance rate gets over 80%, in the case of diabetes, you actually reduce the total cost of care for a patient by almost half. You see the drug costs go up, but that makes sense. You're actually using the drugs properly, but the other parts of the system are less taxed because the patient is actually staying stable and out of the problems we all know that exist with diabetes. We've charted similar results in oncology, in cardiovascular, and neuropsych. It really does work, and it's meaningful. Another thing that Medco's focused on, as I mentioned before, is pharmacogenomics. I've just listed a few drugs here, a few drug categories, disease categories in this chart, and it simply shows you that for these specific diseases, drugs are dispensed where patients may or may not have the genetic ability to metabolize the drugs in the class. And so when you do the math, if you just look at this chart and you do the math, because we practice shotgun medicine today, because, for example, in Alzheimer's, we know 30% of patients respond to the two major drugs in the class right now. 70% are given the drugs. They do not work. They are expensive. We know we're throwing billions of dollars away each and every year in every one of these classes because we don't know which patients are right for which drug. And this is just the tip of the iceberg because underneath that, if you're treating a patient with a drug that doesn't work, they're not getting better. In fact, they've continued to deteriorate, and you're spending money in other parts of the system. So we're hugely involved with pharmacogenomics. We've done a number of studies. I'm just going to give you a couple just to give you a sense of what Medco's doing. One of the things we did some research on using retrospective data is whether or not patients who have the right genetics to metabolize the drug tamoxifen. For those of you who don't know the drug tamoxifen is a drug most commonly used to prevent the recurrence of breast cancer. 10% of the population in this country, women in this country, cannot metabolize tamoxifen because they do not have the right gene that creates the right enzyme to metabolize that drug. This has been known for over 10 years. Yet today, if you wonder how many physicians order that genetic test before they put a patient on tamoxifen versus other available drugs, 1 in 100 orders that genetic test, even though that genetic test has been around for 7 years now. It's likely it'll go 17 years before that becomes standard of practice, where you actually determine before you start a woman on tamoxifen whether they can in fact metabolize it. Well, there's another issue with tamoxifen. There are the gene that creates the enzyme that metabolizes tamoxifen is also used for SSRIs, antidepressants, and it's not uncommon for a physician to prescribe an antidepressant for a patient who has breast cancer. It turns out that the SSRI actually binds the enzyme needed to metabolize the tamoxifen. And in a very large retrospective study, we saw a very dramatic increase in recurrent breast cancer for patients who took an antidepressant with their tamoxifen because literally the drug shut down a patient who otherwise would have had no problem metabolizing that drug. We published this study using our huge database. The FDA has now put a black box warning relative to that combination, and it's made a difference in the way medicine is practiced. I still think it will take 17 years before it becomes standard of practice, which frankly gives malpractice attorneys a field day for quite some time. Another great example is we did a very large 17,000 patient retrospective study relative to the drug Plavix. Plavix is a very widely used drug to prevent clotting. And it appears that when the protocol right now for Plavix is physicians often give the patient Nexium or another proton pump inhibitor to prevent heartburn created by the Plavix. Turns out Nexium or all the proton pump inhibitors actually use the same enzyme that Plavix needs to metabolize. And it turns out through this huge study we did, which we subsequently published, that patients who took a PPI with their Plavix had a 50% increase in cardiovascular event and a 74% increase in risk of a heart attack. And so we published this a little while ago, and I just want to give you a timeline here that kind of proves my point. We published the data, and I can't see my slides from here, but it was in November of 2008. The FDA jumped all over it and put an early warning out in February of 2009, and then they put a black box warning on in June. This was very widely publicized. It was written up in all the medical literature. Medco immediately put these findings into our evidence-based protocols, and whenever our pharmacists saw the combination of Plavix with the PPI, we'd call the doc, get a change. And you can see that in this brief period of time, we reduced, the green line is Medco's pharmacists using evidence-based protocols. We reduced that combination of drugs by 33%. At retail, the use of that combination increased 14%. Why does that happen? Well, it's not about the retail pharmacy. It's about the fact that the physician can't keep up with the evidence quickly. And at retail, they're not organized to do evidence-based protocols and manage care and close gaps in care, so they just simply do what's on the prescription. And this happens all the time, and I would expect that what's likely to happen is this is going to continue for 17 years. It's another opportunity to get sued for malpractice. So I'm going to get to malpractice in a minute. Another great study we did this with the Mayo Clinic back in March of 2010, is we actually have a great ability to recruit patients into prospective studies. We know who the patients are. We know real time when a patient is going to go on a drug like Coumadin or warfarin. Coumadin's a great blood thinner, but it's very dangerous. It's basically rat poison. And we all metabolize warfarin differently. Some of us under-metabolize it. It's metabolized in the liver by one enzyme. We all manufacture different amounts of that enzyme, and we can tell how much of that enzyme we manufacture by doing a genetic test. We decided after the New York Times, Wall Street Journal, JAMA, New England Journal of Medicine, everyone made a big deal about the fact that the FDA suggested strongly in guidelines that you genetically test patients who are on warfarin to make sure you know how they metabolize that drug, because the stats were horrendous. It takes 6 months to get a patient on Coumadin to the right dose, to the safe dose for them. And in those 6 months, 25+% of the patients are admitted to the hospital with a severe bleed or clot because you got the dose wrong. So there was a big deal, lots of publicity, and we were watching the data and watching the prescriptions of Coumadin, and we found that despite this big hoopla and all this press about this very important issue, we started calling physicians to do a prospective study around the drug Coumadin, doing a genetic test that we paid for to see if we could dramatically reduce the time it took to get a patient to a safe dose and dramatically reduce those inpatient hospitalizations. And by the way, these aren't minor hospitalizations. These are really serious, life-threatening, long-term admissions often. And when we started calling docs to get them into the patients into these studies, we found that only one doctor in every 1,000 we called had ever heard of the study, despite all the press. I mean, all the suits knew about it. It was in the Wall Street Journal, for God's sakes. But no one knew. No one even knew what we were talking about. So we started recruiting patients into the study. You know, the process is you need to get the physician to order the genetic test. You do the genetic test, get the results back, call the doctor, change the dose, and you follow them for more than a year to see, in fact, if they have a better outcome than patients who did not have the genetic test. Long story short, what we found is 66% of the time with the genetic information, 66% of the time we changed the starting dose. We found that we reduced to under 3 months, the time it took to get a patient to a safe dose, and we reduced the inpatient hospitalization rate by 31%. And I believe it could have been closer to 50% because we had a phenomenon occur where even though we saw the prescriptions real time, often what physicians would do who are doing elective surgery is they do the elective surgery knowing they were putting the patient on Coumadin, and by the time we did our thing, got the genetic test, got the results back, changed the dose, the patient had already bled out on the drug. So obviously another takeaway here is if you know you're doing elective surgery, do the genetic test beforehand and you'll start on the right dose, and I think you would have gotten to a 50% reduction in that kind of admission. These are the kinds of services that our clients are buying from us right now because the next real opportunity to get at real cost savings without rationing is just being a lot smarter about how we manage the knowledge we already have. And how do we give this knowledge to practicing physicians who need it on a daily basis so that they actually aren't flying blind and they're not practicing in a shotgun way. That's what Medco's been very focused on for some time, and it's made a big difference. So if I were to just summarize the strategy we're deploying, let's take a great example. Let's take Zocor, the cholesterol drug that came out of the FDA a long time ago, and it's now a generic, is simvastatin. But when Merck took Zocor through the FDA process, patients in the trial were on the drug for well over 5 years, very consistently and monitored. The results showed a dramatic reduction in cardiovascular disease if, in fact, you stayed on the drug with longevity. So the FDA approved that drug based upon the data. And so in the real world, you would expect the same results as from the clinical trial. But of course, we all know, tied to the information I already gave you, that that is not what's happening in the real world. In the real world, you're having far less compliance or adherence with the protocol, and the data is not coming through, and the cardiovascular events are happening. So our Medco Therapeutic Resource Centers, using evidence-based protocol, real-time information, is working with these patients, getting them back on the wagon so the results in the real world look the same as they did in the clinical trial. Then pharmacogenomics takes us to the next level, because if we fundamentally understand, even in the clinical trial, there were patients who didn't respond well, and it was often for pharmacogenomic reasons. So what we are now doing is we are actually putting that as a screen up front for those things that are life-threatening, like tamoxifen, like Coumadin, many other tests we're doing right now. We're actually delivering results that are better than the original clinical trial because we're taking the knowledge we have today, automating it, and driving it. So, what I'm describing is an innovation at a systems level to get at total healthcare costs to better coordinate and connect the many silos we have in our healthcare system today. We've taken it one step further. We've put it online. We've taken and dumbed down evidence-based protocols so the patient can understand them. And we basically alert them when they're non-compliant. We have videos embedded to teach the patient what they're doing right and what they're doing wrong. We have the ability for them to actually, if they just, after reading everything and looking at all the videos, they still don't understand, we have a button that they can click to talk to a specialist pharmacist in their disease. They click the button, they type in the phone number that they want our pharmacist to call them at, and within 60 seconds they're on the phone with the specialist to get them trained and get them where they're supposed to be relative to their disease and their protocol. We've now actually released all this in smartphone apps, BlackBerry, all the phones they're in now. So our patients are taking them to physicians and talking to their physicians about this information and where they are, and actually there's a much better conversation going on now today, now that these things are in smartphones, which is what pretty much everybody's using. So I want to just kind of summarize where I think we need to go in healthcare reform. I do think wired healthcare system is the foundation upon which lots of great innovation can occur to improve outcomes and lower costs and actually make the practice of medicine easier for physicians. I think protocol-driven medicine is essential, and I know many of my physician friends say, Dave, I don't want to practice cookbook medicine. I don't really view it that way. I view at this point it's a way to practice better medicine. It's a way to gather data and have a real learning loop that's national, where we We can bring the information to light and then constantly improve these protocols to get the right decision trees in place, to make the right decisions all the time, and just improve our batting average. I think that there are real opportunities once you have those two foundational pieces in place to improve tort reform, the medical malpractice situation in this country, and the Medicare situation. If you just want to look at the math, I told you we are focused on $350 billion of waste tied to the poor management of chronic and complex disease. Medicare, quite honestly, once you get to a wired system and you get to protocols, the next thing you do is you start focusing on medical malpractice, because it's my belief, and I've talked to many medical malpractice carriers about this, if in fact physicians are practicing to protocol, if in fact they are practicing current landmark evidence, the odds of a patient winning a suit go down dramatically. Insurance rates go down dramatically, settlements go down dramatically. We can get at $200 additional billion of waste if we fundamentally get to a protocol documented system. We can eliminate a lot of the $200 billion on top of the $350 billion. It's also my belief, if we have evidence-based protocols that deal with the last year of life in Medicare, that also has protocols in place that makes it possible for physicians to do the right thing without being sued by the family. There's another $130 billion there we can also start to deal with. So quite honestly, a systems approach to the things we do in healthcare in the way I just described really can target getting at $680 billion of waste in this country each and every year. And I hope that soon becomes the dialogue in Washington. It's really not right now. What we're seeing in Washington right now is inflationary, which means we're going to have some very desperate people looking to cut budgets in very, I think, silly ways. And we need to, I think, focus on doing the right thing. And with that, I'm done. Thank you very much.
Well, thank you so much for that, David. It's really interesting to see how Medco is innovating after we've been talking so much here at the summit about medical advances in a very, different kind of environment. But certainly, you guys are. Yeah,
a lot of my physician friends can't believe a company that's administrative can actually innovate. But I hope I'm showing that you can.
Yeah, absolutely. In preparing for this, I did talk to physicians and patients and ask them, what would they be interested in talking to you about? There is definitely some concern. You guys are so automated, and there's some question about whether that does take some authority away from the physicians and from the patients. For example, when Zocor went generic and we had the Symva switch out, patients were going to high-dose simvastatin. We started seeing some muscle problems and whatnot. Also with the PPI Plavix that you presented, some physicians do believe that those still are safe to give together. So what do you say to those? How do you address those issues?
Two different issues and two different answers. So when it comes to high doses of Zocor, the data is clear. Stay on your Lipitor if you need the higher dose, because you do see far more muscular problems on the higher dose that's in the protocol. So you have a properly done protocol, that does not happen. When you talk about Plavix PPIs, the data it's more than compelling. It's off the charts, staggering. The FDA clearly thought so and put a black label on it. So I guess if you still want to consider medicine an art and not a science, and you want to do that, welcome to the malpractice. The data is compelling. Now, one of the things I hear physicians say all the time is, I don't want my judgment ruled out by a protocol, because there's always a reason to make a different decision. And it's my belief that protocols, as I said earlier, are decision trees. And if we widely agree that in this case, with this unique set of circumstances, you don't do that, you do this, that becomes part of the protocol. That's the learning loop that refines how we practice medicine over time. But what we'd love to see is more consistency in practice, because when you look at the data, the diversity is huge, number one. And number two, it's often generational. meaning when you were trained and when you get out of med school, because you see that as you get further and further away from med school and you get consumed by, really trying to make a living, practicing, you saw how much you'd have to read to keep up. And the discrepancy in practice patterns has nothing to do with judgment. It has to do with how recently were you trained on these newer discoveries. And I think it's humanly impossible to keep up. I think we need to get to a standardized approach across the country. You've seen Atul Gawande's writings on this. It's no mystery. The geographic differences, the age differences are all manageable. We can do better. And I do think the practice of medicine would become a lot easier with some form of technology assistance to keep the malpractice headaches away, to help with the reimbursement issues that are always being faced. And I just think, my physician's my father's a cardiologist, and he and I have these debates all the time, because he remembers when, he's retired now, but he remembers when there was no such thing as wiring a healthcare system. You couldn't even talk about it. And half the technologies we have today didn't exist back then, but they do exist now. And we need to create support systems for the doc. My vision is to put the doc in more control with more knowledge that is manageable and actionable than they have today, so that in fact they can help themselves get out of this fee-for-service world, because the fee-for-service world is deteriorating. I think tying outcomes to payment, creating an opportunity for case rates that are manageable, actually is going to be a better life for a physician than the fee-for-service I see going forward. Mm-hmm. And I really think there's an opportunity to collaborate and make medicine better, drive outcomes up, and drive costs down.
What do you think about the idea of the empowered patient? We're hearing a lot about that, how patients are getting more involved. A lot of the stuff that you do is automated. A lot of stuff comes from mail order. Do you worry at all that there's less interaction between the patient and the pharmacist? Sometimes people are saying, you guys certainly are doing a lot automated, but again, that's a generational thing. My mother-in-law is not going to push a button and have somebody call her. Mm-hmm. So how are you managing that, the empowered patient?
So the difference between retail is a very important part of how we serve our patients, so I'm not going to diss retail, but there is a very big difference in the practice of pharmacy between retail and what we do at Medco and mail. If you go to a retail pharmacy today, and I know probably everyone in this room has, there's a fiction being portrayed that, always a pharmacist comes up and says, "How are you, Mrs. Jones? Do you know how to take your med and all that?" That's not what happens. You have a high school student giving you the bag of drugs that was on the shelf. They have you sign something, and many people don't even realize what they're signing is something that says you don't need to talk to the pharmacist. And you walk out with your drugs, and that pharmacy isn't looking at you as an end-to-end patient. They're looking at you for the script they're giving you. So they aren't looking necessarily at all the other drugs in your profile, not only that came from their pharmacy, but from all the other pharmacies that patient goes to. Now, we push that information to the retail pharmacy, but they're so busy putting pills in bottles, they often just say, physician's discretion, and they don't even take the time to call the doc to make sure when they see a drug-to-drug interaction being presented on the screen. Our pharmacists don't put pills in bottles. Robots do that 23 times more accurately than human beings. So our pharmacists 100% of the time are talking with patients and physicians. And by the way, when our pharmacist calls a patient, unlike a managed care company who gets 30% uptake on those phone calls, we get 85% uptake, and they want to talk to their dispensing pharmacist. And it's often a more private environment when you're talking to a patient in their home or where they choose to call you, as opposed to standing in line in a retail pharmacy. So I think there's a little bit of fiction being spun there. I think it's very powerful, and as I already mentioned in my talk, we're pushing this information to people who are technology savvy, online. It's very robust, and we're pushing it to their smartphones now, and we are encouraging them to talk to their doctor. Because the doctor would like to know they're non-compliant. We often, if it's really important, we're picking up the phone and calling the doc about their patient's non-compliance, and they're usually saying thank you. So I think it's a real advance. I think it takes some getting used to, But I think as healthcare gets more complicated, these support systems become more important. And it's the only way I think you can manage risk if you're contemplating going into an accountable care organization. Right now, the regulations are horrible, so I wouldn't do it. But you have to believe they're going to get fixed so that it actually makes some sense. Cleveland Clinic's the perfect place to get into accountable care when the regs are right.
Exactly. Well, the work that you guys are doing, the innovation that you're doing is really incredible. You know, it would be remiss of me not to mention that you guys are in the middle of a $29.1 billion merger. Ironically, some people have worried that that's going to increase costs and that's going to, limit access. The things you guys are doing are pretty remarkable. It seems like if you had more people under this umbrella, it would be better. I know that you've been making that point. Are people hearing you?
So far, so good. We did a House committee, Judicial Committee hearing recently, and that went on with came off without any static. I think people understand it. One of the most powerful points for me to tell people is our clients. The day the deal's done, $1 billion in savings across my client base happen immediately. Under the current contracts, no renegotiations, no nothing.
How does that happen?
Because we're taking best of contracts that you do in a clean room tied to a merger, and you just look at the various contracts. You take best of breed, put them together. Our contracts with our clients are transparent. If the rebates improve, they get the rebates. It's $1 billion right to their pocket.
For employers who hire you?
My customers.
Yeah.
My customers, the people who pay the bills. And depending on their the design of their benefit plans, it also gets down to the patient. Mm-hmm. So it is powerful, and I think a reality is if we're really going to, what healthcare reform, no matter what happens next year, and there's so much that's going to happen. You've got the super committee slashing the healthcare budget, guaranteed. You've got the Supreme Court deciding on the constitutionality of the mandate for the exchanges. And you've got a presidential election, and they're going to feed upon each other. The rhetoric is going to be incredible. At the end of the day, the one thing that's going to be common for all of us to accept, we're going to be asked to do more with less. And in my world, better, faster, cheaper, more scale through my fixed assets is going to drive costs down. And I think you're going to see mergers of healthcare companies of all types, pharma, health plans, hospitals buying docs, health plans buying doc practices, trying to consolidate, trying to get scale so that they can deal with accountable care, so that they can deal with some of the pressures that are going to be exerted on the entire healthcare industry as we try to get our costs under control and drive outcomes up with lower cost. It's a reality. This scale thing creates savings. Every time you get more scale, you save money, and everybody benefits. So long as we fit within the FTC rules, the Federal Trade Commission rules, this deal makes all the sense in the world if you're really committed to healthcare reform.
And if the deal doesn't go through, if something happens, the market's betting against it at the moment when you look at the spread. Foolish market. Yeah. But you're in good shape. I mean, looking forward, United Health.
Either way, you know what? We're here to play. We want to do the right thing. We've always been committed to doing the right thing. We'll continue to do the right thing. And we'll continue to grow, and we'll just do it in different ways. So we're in it one way or the other, but this is the smartest and the fastest, so that's what we're going to try to do.
Excellent. Thank you so much for your time.
Thank you.
Thank you.